Cool. So thanks to everybody for being here and for having me today. As I mentioned at the top of this session, my name is Jon Zelner. I'm an associate professor here in the Department of Epidemiology, and my research group focuses on the transmission of infectious diseases, kind of writ large, but with a particular focus on sort of spatial and social dynamics of infection risk. And so as you might imagine, we've been fairly busy over the last number of years, looking at things like the COVID pandemic. And today I'll talk a little bit about the emerging measles outbreaks in the United States. But we do this through the lens of epidemiological modeling, which is a term that is about as fuzzy as the term AI. So I wanted to kind of start out with, for anybody who isn't familiar with this area, although I think many of us became kind of perhaps too familiar with it during the kind of at least early to mid phases of the COVID pandemic, a little bit about how I think about this and how we approach it, and then kind of where we are in this AI journey, right? And so the work that I'll be talking about towards the end of the talk is supported by one of these Midas Pods Award, which has been incredibly helpful for kind of taking our research in a new direction. So obviously this is a session about trust, and Fraser's talk was great, and it's kind of a hard act to follow. I get to play the role of mid-career scientist who talks about the cool work that other people are doing. So I'll give that kind of high-level overview, but I can't promise the nifty kind of methodological detail that he was able to give. And so I want to talk a little bit about what it means to build trustworthy AI-augmented infectious disease models, right? How we think about that, why it's important, and a little bit about kind of what's coming on next down the line. Okay. So, like I said, much like AI, epidemiological modeling doesn't really have a clear definition. I think in the kind of going back into the sands of time when I was a graduate student here in the early 2000s, I think we would generally say it's differential equation models that we fit to time series data. And maybe if we're feeling adventurous, we'll think about partial differential equations and some spatiotemporal stuff. But as time has gone on, the number of data sources available to us has really increased, right? And so the challenge of developing these kind of causal mechanistic models and then fitting them to real world data has become exponentially more difficult, or difficult if we want to be able to use those sources. So, my working definition of what it means to do epi modeling here is doing, from a computational and theoretical perspective, what it takes to ask the questions that we really want to ask of our data in a mechanistic way. So sometimes that's going to look like a differential equation model. Sometimes that's going to look like an abuse of a logistic regression model. Sometimes it's going to fall somewhere in the middle. So this being a talk about sort of AI journeys, I just kind of wanted to talk about the way that I see the extension of our work into something that is kind of AI adjacent or ML related. So we, as a research group, we call ourselves epi-based. We've always had a really, hierarchical Bayesian modeling focus. And the way I see it is the work that we're doing that is kind of sitting in more of this AI and ML space is kind of the logical next step in the things that we've been doing. So it feels not so much like a discontinuity, but in a good way, like a positive extension of the things that we've been doing over the last number of years. So, when we talk about epidemiologic modeling, we're really talking about inferring the mechanisms of transmission. So this is where, you can run into trouble if people perceive your model to be too much of an uninterpretable black box, right? And so the kind of work that we do is really focused on creating more accurate and interpretable and overall trustworthy estimates of key parameters and population level effects. And our models are all inherently integrative, like I mentioned, right? So we focus a lot on spatial and temporal data. We focus also on pathogen genomic data for hospital-acquired infections, for things like tuberculosis. And what we want to do in a world where, infectious disease data, particularly in emergencies, comes at you from many different sources with many kinds of observational biases. And what we want to do is to kind of take as much information as we can and pull it all together, right? So the way I think of our uses of things like AI and ML is in the role of a kind of very, very high dimensional smoother that's letting us borrow information from one place or another. So kind of coming a little bit out of that kind of Bayesian hierarchical world. And we work with a wide variety of stakeholders, right? So this includes, the CDC, although, sometimes we're not sure if they're allowed to talk to us anymore, but also state and national public health stakeholders, local stakeholders like Washtenaw County Health Department, and also community activists, right? And so we always try to phrase our results in normal human language, right? So on the right-hand side, you can see the results of some work by a recent PhD graduate from my group named Ramya Narasethi. And Ramya's PhD work was focused on understanding the impact of timing of infection on racial and ethnic disparities in COVID-19 deaths in Michigan. So what you can see, the basic idea is if you kind of remember all the way back to the bad old days of January and February 2020 or March 2020, people who got infected early on in the pandemic were far more likely to die than people who got infected even a month later, right? And this has not much to do with immunity or vaccinations, obviously, because those weren't available, or antivirals. It had a lot to do with the fact that that first couple of months was a period of a lot of experimentation and figuring things out, right? So you might remember stockpiling ventilators, which then turned out to not be a particularly useful thing to do in terms of supporting the respiratory health of COVID patients. So there was this kind of period of learning that happened relatively rapidly so that the case fatality rate went down very precipitously early on. And so we were able to take data from the Michigan Department of Health and Human Services and calculate not only the incidence rate in different groups, and this is early on when we can kind of trust the testing data, we could also look at who died and when, right? So why is this important? This is important because one of the prominent explanations for race and ethnic disparities in mortality from COVID at this time was that people of color in Michigan, this was a real focus on African Americans in particular, had lots of comorbidities that made them more likely to die after exposure. And that's a story that, like, if you squint, maybe makes some kind of sense, but it wasn't based in any kind of data. And what we could see in looking at these data was that the truth is that the differences in who got infected were much higher between race and ethnic groups than the differences in who was at risk of death conditional on infection, right? So this is all like plain vanilla hierarchical regression modeling where we asked a counterfactual question and said if everybody got infected on the same time scale as white folks in Michigan, because that was the only basis we had for comparison with the data we had, what would the disparity, how many deaths could have been prevented, right? So in this case, we see that among Black Michiganders who were infected in 2020, maybe 35% of those deaths could be reduced, okay? So this is not an AI model as such, but it can be hard to ask and answer these questions with limited data or a single type of data and the relatively simple models that we had access to. And so when I talk about kind of where we're going with this work, it's being able to ask and answer questions in the terms that make sense for public health instead of just giving you some parameter that says, this is the relative risk of death for these people versus these people. We get to ask a more mechanistic question. Sometimes we can do it with, boring, plain old hierarchical linear regression models, although they're not so boring. But sometimes we need something a little bit stronger. So, we're talking about trust, and I think trust, when we talk about AI and we talk about models, kind of happens, there's two trust questions, right? So one, and one that Fraser talked about, kind of talked about both, is do we believe the model is doing what we think it's doing, right? And do the people who are impacted by the things we do because the model told us to do them believe that we're doing the right thing, right? So obviously public health in the United States has long suffered from a crisis of trust. The anti-vaccine movement was in ascendance well before the COVID-19 pandemic, but obviously it's really taken off not only during the pandemic, but in its aftermath. And of course, now we see, an anti-vax activist at the head of the Department of Health and Human Services, right? So we've come a long way and not in a good way. So this is a quote from a participant in a study about trust in the COVID-19 vaccination, who's talking about, this sad and difficult history of, medical and scientific racism in the United States. And, they hear about a vaccine that in truth is life-saving, and their first thought is, what's wrong here, right? So this current of mistrust, regardless of who you are, what socioeconomic group you belong to, runs pretty deep. And we know that this erosion of trust has really created the conditions for public health disasters. So this is some work by a collaborator of mine who looked at the spatial clustering of non-medical exemptions to vaccination in California in the mid-2010s, right? And so you can see these areas where you have these pockets of non-vaccination, and these are places where, against measles specifically, these are places that are at really high risk of taking off and having an outbreak. And of course, we don't need advanced epidemiologic models to see where all this mistrust was going, right? So this is from last week. This is in the New York Times, the ongoing outbreak of measles, this kind of cross-border outbreak of measles in Texas and New Mexico that probably most of you are aware of. Just looking at a map like this, and you could do this anywhere in the United States, you could certainly do it in Michigan, and you would find these bright red areas where you would expect these outbreaks to happen. Looks a lot like a paper that was published in Science way back when in 1972 on the other side of Texas, showing a cross-border measles outbreak where there were many more cases in Texas than Arkansas. This is kind of the line down the middle is the state line separating Texarkana, Texas from Texarkana, Arkansas. And Arkansas at the time had a much stronger vaccination regime, and so you had a much smaller, much lower incidence of measles, right? So this is all like pretty commonsensical stuff, right? So I'm kind of talking myself out of a job here a little bit, right? So why does any of this stuff actually matter? So first of all, we can know this. We can know that there's this outbreak going on in Texas and New Mexico. And we can know in a qualitative sense that there are other places in the United States or in Southeast Michigan, wherever you pick your place, where there are a lot of folks who are unvaccinated against measles, or too many right now, and we should expect to see outbreaks, right? But what models in the best case let us do is say something about where those outbreaks might happen next, right? But that's a pretty data-intensive exercise. And when we think about trust, if we think about the failures of the COVID-19 models, a lot of them were really rushed out. They were kind of based more in hunches than data, or used a very limited set of data and made pretty weird predictions, or ones that were interpreted by certain actors in certain ways and really decreased anybody's sense of trust in what those models were doing, right? So this is the kind of thing where you really typically only get one bite at the apple. And so when we're doing this, we got to do it right. So, in our work, we think about prevention and response, right? So we think of, how do we build tools that let people have a better sense of what's coming? So this is from a theoretical modeling paper we did a number of years ago, looking at how the scale of observation for measles non-vaccination impacted our ability to detect areas at high risk of outbreaks. Because in general, vaccination rates are only reported at a county level, sometimes even at a state level. But we know that it's local communities where there's a shared reason, maybe it's religious, maybe it's ideological, that people are unvaccinated, they're at most risk. And so by conducting this very theoretical exercise, we're able to say, if you only report these data way up at the state level or the county level, you're going to totally miss a lot of the risk, right? So we can simulate forward these kind of interesting and important patterns, but fitting this model to real data is non-trivial, right? And presents all kinds of interesting problems. And obviously this kind of overall, atmosphere of mistrust really raises the stakes for anything that says we're putting AI or we're putting an ML model or putting a neural network into some epidemiologic model, right? You don't want to put people's kind of antenna up and say, oh, this is a black box. This is something we can't trust. This is a quote, right? So my question to you, I think you know the answer. Is this a hallucination of an LLM or the current HHS secretary? No, in fact, it is our good friend Robert F. Kennedy Jr., who kind of promulgated this idea that, well, you can't really die from measles, which is untrue. You can also go blind, you can go deaf, you can have neurologic damage. If you're pregnant, you can suffer fetal loss, and that it's all about, malnutrition. Like, why am I putting this up here? Like, it's fun to dunk on RFK Jr., right? But that's not exactly why I'm doing it. This is kind of another form of smoothing in some sort of sense, right? It's not deep learning, it's fairly shallow, but it's pulling a bunch of threads together and telling this kind of coherent, if you hear it in the right tones, very like overdetermined story, right? So I think, that's kind of what we're up against. But, at the end of the day, at its best, epi modeling is this integrative enterprise, like I talked about, that brings diverse sources of data together and lets us say something meaningful about the data that we have. And, to be useful and trustworthy, these models have to be drawing on high quality data in ways that are logically coherent, unlike RFK, and transparent. So one analogy here is what we're trying to do is to build something that looks a little bit like a stone wall. Like we're pulling in, and this is an analogy from a paper by a philosopher of science named Tricia Greenhall. We're trying to pull in information on the spatial locations of cases, the social attributes of individuals who are infected and those who aren't, maybe pathogen genomes that can tell something about who infected who, right? Because each one of these data sources has different kinds of errors, different kinds of observation biases, and we want to build models that aren't just premised on one type of data. We want to have the stone wall where we've got these different pieces of information that kind of hang together, and if you knock out one of the stones, the whole thing holds up. Rather than the relative fragility of something like a brick wall. Obviously, a brick wall is not necessarily particularly fragile, but if you make it all from the same batch and it turns out they're lousy bricks, then you don't have much of a great situation, right? So the analogy here is the more diverse the data we can pull in, can you guys hear? The better we can hope to do with our predictions and so forth. Sure. But like I mentioned, fitting models to data is a difficult task. I'm going to kind of skip past here in the interest of time, but these models have really, even under the best of circumstances, a really large state space, right? So pinning down this relationship between model and data is non-trivial, even when you're dealing with a relatively simple deterministic model. And these problems become more acute when we're trying to integrate other sources of information, the dimensionality of the state space. If we bring in, genomic data might more than square, right? Because we're thinking about multiple kinds of distances. How far apart are different cases, how in genomic space, and how far apart are they in geographic space? Similarly, if we want to think about infection inequity, which is a big focus of what we do, we want to be pulling in social, spatial, economic, health data, the whole thing. So, this is a big wind up to where does this all come, where do we end on our AI journey here, right? It's very hard to write the likelihoods for these models in some kind of straightforward way. So simulation is a really is a convenient way to generate trajectories or samples that we can then use to compare against data. And the most common simulation-based approach is something called approximate Bayesian computation, where essentially we pick a vector of descriptive statistics and we pick and then we simulate out from the model and we say how close are you to the data, and if you're close enough we accept you, and if not, you're gone. But this can be brittle. It's really dependent on our choices of summary statistics and the accept-reject threshold. So one area that we're working on is, and this is our MIDAS supported project, is called neural posterior estimation. And this is essentially where we put a feed-forward neural network in the middle of our Bayesian workflow, and we train it on the simulated outputs of the model, and we teach the simulator to essentially invert like we would with a likelihood function. So if I give you a vector of input data, it'll spit out a posterior distribution of parameters that correspond to that, right? And the nice thing about this is that in contrast to ABC, our well-specified MPE model is going to do a better job of actually learning the features that matter in the data. So it's not necessarily so dependent on me knowing what the right features are, picking a good accept-reject threshold, but instead the model gives us a little bit more flexibility. So this is why I kind of see our journey as a very important and productive, like one step beyond what we've been doing, but it's a pretty big step. Okay. So, what's next? Essentially, we're starting simple with models of hospital-based infection transmission, but where we're hoping to go is on some of these larger projects where we're looking at the spatial distribution of cases of, in this case, methicillin-resistant Staph aureus or MRSA in Chicago, and its relationship to things like mass incarceration, because jails are a well-known site of amplification for MRSA risk and the emergence of drug resistance. And so, we have all of this contextual data, we have incidence data, we have social information, we have a couple thousand sequenced genomes, and we're hoping to go in the direction of being able to ask these more mechanistic, policy-focused questions of these models, but in a way that's like transparent, and where the AI or the ML is kind of off to the side. It's helping, but it's not the center of the show, right? It's a pathway to explanation and to trustworthy modeling rather than kind of a central feature of the work that we're doing. So I'll pause there. Hopefully I'm not too far past time. I don't know if we have time for questions or.
Thank you for the great talk. So I was curious, how far are we on this effort in prediction simulation? So let's say if we have, let's say like a relatively new disease or, all diseases with different mutation, how accurately can we simulate the spread of these diseases at this point?
Yeah, it's a great question. So, I guess what I would say about that, so there's kind of two questions. I would say in general, our ability to predict things is pretty lousy, right? And that may just be a feature of the fact that these are very uncertain systems, right? So I'm a skeptic of forward prediction beyond a very narrow time horizon, right? Of forecasting out more than a week or so. But what I am more enthusiastic about is kind of more cross-sectional prediction, right? Thinking about who is likely to be at risk at what time, what populations, maybe that's spatial, maybe that's socio-demographic, right? So I think it's like changing the target, right? Moving the goalposts is actually a productive thing, because most of the time what we care about from an operational perspective is who's going to be at risk, over the next month, the next year, whatever. So I think we do a pretty good job in that space. When it comes to emerging infections, right? I know not everybody had as close of a view of the early days of the COVID pandemic and the modeling that went on there as folks who work in our field did, but there was you probably were familiar with the idea that there was a real scramble, right? Like the volume of preprints coming out, people kind of guessing what is this thing, right? So that's where simulation-based inference modeling is really, really important and potentially really helpful, right? It's a lot easier to spin up a simulation model than it is to write the likelihood function for these things, right? And if you have a network set up that you can train on a wide variety of spatial models that incorporate genomic data and temporal data and all of this, then if that works for a wide variety of models, when the next thing comes along, you can do that process of spitballing in a way that's not just like taking a guess, fitting the model to the data, in the simplest way possible, and just hoping, right? It gives you, you get to move a lot faster, right? You can code the simulation model up exponentially faster than you can do the inferential one, and particularly if you're bringing in more source of data, and then you can start fitting that to data closer to real time, right? That's where we're hoping to go. But my perspective is more, we want to do a better job of explaining what's going on in the current moment or the recent past, and probably leave forecasting beyond a very kind of narrow horizon to the side. Does that answer your question? Yeah, thanks.
So my question is about, in terms of outside the black box and not at individual model level, but at sort of a repository of model level. And the reason I'm asking this, right, is that when we do our research, we always feel like our data is good enough,
Right.
And our model is good enough, right? And that's why we are confident enough to publish them. But, objectively, there are weaknesses for each model and each data set. And so for some of so epidemiology is probably especially amenable to this kind of, examining an ensemble of models and then look and see if there are discrepancies, where the discrepancies come from. Like a lot of, other fields also do this kind of. So how do you weigh, you're checking your individual work versus the role of comparing to with all the other models and yeah.
Yeah, no, this is a great question. Thank you. So I just had an NIH proposal rejected about this. I wish I could say it was because of funding cuts, but it wasn't. So you're exactly right. Like the mapping particularly in this kind of modeling of like models to problems is many to one, right? Or models to questions, right? So there's a tendency, and this is one of the big failures, I think, of the COVID era modeling, was people would kind of glom onto their own horse in the race, right? But the questions were like, what is the impact of the COVID vaccine? What is the transmission rate? What is the case fatality rate? Is there a spatial signature to spreading, and so on, right? Those are the questions, but then we would substitute models for questions. So like you're saying, ensembles can be a really powerful tool for doing this, right? Ensemble modeling gets used a lot in like forecasting, but a lot of the time those models are not, by definition, are not really geared at explanation. They're really geared at doing better one-step ahead prediction, which is a valuable thing to do if you're being realistic about what you can forecast out. But the way I like to think of this is more of kind of like a multiverse perspective, right? Where we say, we're going to define a whole suite of models that all kind of reasonably map onto the question, right? And this is like a social process. This is like talking to experts, talking to people in the community, scratching your own head and seeing what comes out, right? And then, in an ideal world, when at the beginning of a public health emergency, I'd have my like 200 models that represent what I think a new viral respiratory pandemic might look like. And then, we can, using something like MPE, this is one of the next steps that we want to take, is we don't have to, like you're saying, go one model at a time. We could train our simulator on the multiverse and then use that either to spit out model-specific estimates or some marginalized posterior over all of the models. And then we could do kind of iterative model selection over time, right? So kind of a prior over models, stuff that would be just very hard or impractical to do with classical NCMC, but that you could envision working well in this world. Although obviously, there's a lot of work between here and there. And one thing I neglected to mention is the student who did most of this work on the MPE stuff is named Prayag Chatha. He's in the stats department here, works with Jeff Regier, and also Fan Bu in Biostatistics in School of Public Health. So this is very much this interdisciplinary collaboration. And I'm probably the least qualified person to talk about the details of the networks, but my perspective is kind of the overarching modeling questions. Does that answer your question?
Okay, thank you so much.
Yeah.